So, as Kiana said, we also run a fellowship in cancer survivorship, basically. It's reconstructive urology and genitourinary cancer survivorship. A large part of that has to do with incontinence, what we're going to talk about first. So I'm going to try to split this into two sections. What Kiana asked us to do is kind of tell everybody surgically what makes things different when we're dealing with men. This is going to be geared towards post-prostate cancer treatment incontinence, radiation or surgery. What makes us choose different devices and why we might treat them differently in clinic, and what makes our outcomes differently. Then we'll talk about urethral stricture disease, which is really a trauma issue, but it's scar tissue in the urethra. And I'll try to tell you some things on why we do different surgeries, why their catheters may stay longer, why we do x-rays on some and not others, this type of stuff that you might see. So if you're helping out in the OR, hopefully we'll give you some guidance with that. If you're providing care for patients in clinic, hopefully we'll be able to give you some tidbits that will help with that as well. Let's start out with something that's really near and dear to my heart. Post-prostate cancer treatment incontinence. In other words, how many men leak urine that bothers them and causes problems after they've had radiation or surgery. And if you look in the literature, it's reported to be anywhere from 2.5% to 98% after surgery will leak urine for an extended period of time. And it's affected, historically we thought, by the surgical technique and the age of the patient. But there's been a problem with our research in how do we define incontinence. Is one pad a day enough to leak that we're going to say you're a leaker, or do you have to be leaking 1 liter a day? Now, if I were wearing a pad a day, I'd be really bothered by it. But some people aren't bothered by that at all. So if you're leaking a pad a day and you come see us in clinic and you've waited to get an appointment, we think that that's valid to treat that patient. So there's been a real problem with that. And then how do we define incontinence? Do we have to see it leak? Do we have to do urodynamics? Do we have to do special studies? So there's been a lot of problems with the literature reporting those types of things. That led us to take a look at a database that I had access to when I was in the Army called CPDR, Center for Prostate Disease Research. What I really love is I love using what I call accidental data. Data that the cancer folks are keeping to look at their outcomes for like PSA rates, margin rates, and stuff like that for prostate cancer. And sometimes hidden in there is a lot of quality of life stuff that nobody's looked at. We got permission to look at the quality of life issues in CPDR database. This is a database that's prospectively managed, and we queried it from 1990 to 2007, and we found about 6,700 men who had data entry in there from trained nursing research nurses. And there was a survey question that said, it was a binary question, yes or no. Do you now leak urine after your prostate cancer treatment, yes or no? And what we found was that of those patients that answered that question, we found that over 98% of men who had some form of treatment after prostate cancer therapy checked yes to that question. A lot of problems with that because I don't know if that was urge or OEB or stress incontinence, but still we had a very large group of people who were coming in and saying, I still leak urine after my prostate cancer treatment. And we looked at stage of cancer, experience of the surgeon, age of the patient, BMI, all these different things. The only thing we really found was a slight difference in the age of men who leaked and didn't leak. 68 or 62 years old, if you had an RRP, you leaked a little bit higher than if you were 58. But that really isn't that clinically relevant. That's just a difference of about 4 years, right? So in other words, if you're over 65, which most men are who get the prostate treated, you're going to be at that risk factor. And interestingly, with historical ways that people described leakage or risks for it, and we used to blame it on the patient. We'd say the comorbidities are your problem. Your BMI was too high, you had hypertension, you were an active smoker, this type of thing. When we controlled for all that, we found that there was no difference in people who leaked and didn't leak based on all of the factors they brought with them to the operating room. And that held true over 13 years of follow-up for these patients. And then we also thought that if you did special techniques in the OR, like you spared the nerves and you didn't spare the nerves, you'd have less leakage. Guess what? This database is a cancer database, showed no difference in the people who had nerve sparing or not. So in other words, there's a problem with this disease. I'm embarrassed to say that most of my practice is treating men and women with incontinence that are cancer survivors, but at large parts treating men who are cancer survivors. And I have to tell you, I don't know why some leak and some don't. So we can't blame it on the patient. We shouldn't blame it on the surgeon. We just blame it on the operation. That's when we start calling this a side effect of life-saving therapy, and that's what we've kind of sold to our cancer physicians at Duke. And because of that, we've seen a much larger referral of people coming to us. Unfortunately, if you're in a very competitive environment like New York City or this kind of thing, patients are going to go to the person down the street who's going to say, my incontinence rate's 0. But I'm going to tell you, everybody has an incontinence rate after prostate surgery. This is a meta-analysis out of European Urology, the highest peer-reviewed quality journal in urology. This is last year, 2021, and this is taking all prostate cancer studies that had 8-year follow-up. And the question was, is the outcome of cancer different over different types of cancer? In other words, if I had high-risk prostate cancer, are my outcomes for cancer cure better or worse? If I had a high-volume surgeon or experienced surgeon, are my differences attributed to that? Or if I did it by the robot or laparoscopic or open, are my differences for cancer cure different in those groups? Again, I love finding accidental data. Accidental data in this paper, this large table, this red box at the bottom, that's not even talked about in the paper. You can't see it, but you don't have to. For experienced surgeon, high risk cancer, intermediate risk, low risk cancer, overall, there's one spot here that says percent incontinence with 8-year follow-up. And guess what that percent incontinence is at 8-year follow-up in every one of those groups? It's 20 to 25%. And they don't even talk about it in the paper. Accidental data shows that we still don't understand why men leak. And it's not a scarlet letter if somebody's leaking afterwards. This is a chart from 1996 taking a look at new versus old techniques of prostate surgery. And guess what the rate of incontinence is? It's around 20% at the end of that. So we haven't really improved this over the last 40 years, to be very honest with you. So it's a problem. It still comes up. We still don't know how to prevent it 100%, but it's a side effect of life-saving cancer therapy. If you're working in a cancer institute or you're seeing prostate cancer patients, how many of you see them come back and actually are we asking, are they leaking? I think we're getting better at it now, right? We've got EPIC questionnaires. Are you guys acting on those and sending them for treatment? Perfect. Years past, what we saw in our facility, and it took us a decade to change it, was your PSA is 0, you're doing great, I'll see you next year type deal. We're getting, I think, a lot better, and it's actually our advanced practice providers that are really driving this train. As surgeons, we focused on margin rate and PSA, and I think our APPs are really, really sensitive to looking, really holistically treating ED and all the rest. There's a lot of data now that I don't have a slide on because it's brand new. Incontinence in men, women as well, but men don't tolerate it as well, nearly as well as women do, leads to depression, anxiety, anger scores, a very big problem called decision regret, meaning I shouldn't have gotten that radiation or I shouldn't have got my PSA checked because now I'm in diapers, and reclusiveness, problems at home, and probably actually has a significant suicide rate that we haven't addressed yet. So this can be, I think, a really, really huge quality of life. And what I'm going to show you is we've got tons of options, outpatient surgery options, that are very well tolerated, even in really sick patients who have high comorbidities. We can do these people a lot of good. I get asked a lot, does pelvic floor rehabilitation actually help with post-prostate cancer treatment and incontinence, radiation and surgery, or even combined? Well, what we find is early studies show that it probably did. But if we looked at these early studies, they only went out about 8 or 9 weeks. And they definitely showed an improvement in leakage rates in men who did pelvic floor PT. The problem is, if you actually did those studies and you followed them out longer, what you learn is that it doesn't change the overall rate of people who are going to leak, but it makes the people who are going to get dry a little bit sooner. So it definitely helps, but it does not change the overall rate of incontinence. So if you're seeing somebody in clinic and they're a year out, the pelvic floor therapy is probably not going to help them at that point any longer. So sending people repeatedly for PT and that kind of stuff at that point is not going to help. Where it's going to really help is early on in their treatment. Once they get to that stabilized thing 12 months out, it's time to start thinking about other types of interventions if they do have significant stress incontinence. So this is a study out of European urology as well. It goes out to 12 months, and you can see that that blue line's where they got PT, and the red line's where they didn't. It just moves that line to the left, but the overall rates are very similar when you look at them.